Welcome back to the deep dive. Today, we're really getting into the clinical side of pediatric dentistry.
Yes, specifically looking at how professionals guide children's behavior in the dental setting.
Exactly. We've gone through a lot of sources that detail this whole science of behavior guidance, and it's not just about, getting a filling done.
No, it's much bigger than that. It's about shaping the child's whole view of dentistry, maybe even healthcare long term.
Right. So our mission today is to give you a really detailed, comprehensive look at the strategies dentists use. Reducing fear, building that crucial trust, and hopefully instilling a positive attitude right from the start.
And I think, first off, we really need to be clear on the terms. You hear behavior management thrown around, which, okay, that often just means controlling the situation so you can do the work. But what we're really focused on, based on these sources, is behavior guidance.
Okay, so what's the key difference then?
Guidance is, well, it's a continuous thing. It's the whole approach, the methodology the team uses, not just to get the treatment done effectively, but also at the same time to actively reduce fear and anxiety. It's about building a relationship, really.
A relationship that lasts past that one appointment.
Precisely. It's long-term thinking.
That definitely changes the perspective. So if guidance is the goal, the sources lay out some core objectives, right? The sort of why behind it all. I think there were 4 main ones.
Yeah, 4 key objectives. Number 1, establish effective communication. And that's with the child, obviously, but also crucially with the parent.
Right. That two-way street.
Exactly.
Yeah.
If you nail that, then you can move to objective 2, gaining the child's confidence and, importantly, their acceptance of the treatment you're proposing.
Makes sense.
Third is the educational piece.
Mm-hmm.
Teaching them about preventive care, why it matters, making it positive. And fourth, and this one sometimes gets missed, is creating a relaxing, comfortable environment, which, isn't just for the child. It helps the whole dental team work better, safer, more efficiently.
That's a really good point. Okay, so those are the goals. But before you can even think about techniques, you need to understand what you're working with. Let's unpack the factors that influence how a child behaves in the chair. The sources seem to group these into 3 buckets.
Yeah, that's a good way to put it. 3 main categories: factors related to the child themselves, factors related to the parents, and then factors related to the dentist and the environment.
All right, let's start with the child. What internal stuff are we talking about?
Well, it's quite a mix. You've got their psychological development stage, any existing anxiety or fear, their physical health, things like school influence, whether they actually understand why they're at the dentist, and even their general intelligence level plays a role.
That developmental stage seems huge. The sources really drill down into age-related milestones. Like newborns, they already have basic emotions: fear, anger, joy.
Right, and their emotional growth comes from exploring. Then you hit age 2, and it's all about motor skills. Their attention span is, well, tiny.
Yeah.
And communication, purely emotional. They have to sense kindness. Crying is pretty much expected.
Okay, then age 3. Things shift a bit.
Yeah, a little more independence starts creeping in. They respond really well to praise. It's sometimes called the Me Too age. They like conforming. And importantly, you can start reaching them with words. Being separated from mom or dad isn't quite as big a deal.
And then 4, this age sounds fascinating based on the readings. The how and why stage.
Exactly. Super inquisitive. They talk a lot. Generally cooperative. But, and this is the kicker, fear actually peaks around age 4.
Wow. Peak fear, but still considered a good age for the dentist. How does that work?
Because you can use that inquisitiveness. You can talk to them, explain things, reason with them, provided you respect that underlying fear.
Yeah.
It's a delicate balance.
Okay. And then by 5 or 6...
fears tend to go down. They start being able to evaluate situations better. And crucially, they can tell truth from falsehood. This is why the golden rule emerges. Never, ever lie to a child this age.
Huge.
Yeah. They love praise, and they're becoming more independent as their world expands beyond just home.
So, moving from age to emotions, anxiety versus fear, we use them interchangeably, but the sources say they're distinct.
They are. Anxiety is that apprehension, but from an unknown source, a general feeling of unease or threat. Fear is different. It's primal, and it's tied to a recognized source like seeing the needle or hearing the drill.
And that triggers the fight or flight.
Directly. Now, there isn't a super clear line between them. They definitely overlap and can make pain feel worse. But knowing if it's generalized anxiety or specific fear helps guide the approach.
And fear itself isn't monolithic either. There are different types.
Right. 2 main types. First, objective fears. These come from direct experience, something they actually felt, saw, or heard that was unpleasant, like a previous painful injection. Or even associative fear, like being scared of white coats after a bad hospital visit.
Okay, direct cause and effect.
Then you have subjective fears. These are trickier. They're based on feelings or suggestions picked up from other people, usually parents, sometimes peers.
Ah, like hearing mom talk about how much she dreads the dentist.
Exactly. And a child's imagination can really run wild with these suggested fears. Observing a parent's fear is probably the most common way kids acquire them.
And the sources pointed out something really interesting here, that subjective fears can actually end up being more intense than objective ones. Why is that?
It boils down to limits. An objective fear, based on a real event, has boundaries. You remember the pinch? It lasted a second, then it was over. Subjective fear, absorbed from someone else's dread. It's not tied to a specific memory or event. The child's imagination isn't constrained by reality, so the perceived threat can become enormous, vague, and much harder to tackle because it's not based on anything concrete they experienced.
Wow, that makes the parental influence incredibly powerful then.
Immense. And, the sources are pretty direct about this. Often the parent is the main challenge, not the child.
Okay, so let's learn to those parental factors. The sources talk about 7 attitudes.
Yeah, 7 patterns that can cause issues. You've got things like over-affection or overindulgence, basically. The parent doesn't set boundaries, spoils the child, leading to resistance and selfishness, especially towards something like dental work.
The passive enabler type.
Kind of, yeah. Then there's the flip side. Overprotection, over-anxiety, over-authority. This creates dependency, timidity, or sometimes a kind of tense, submissive behavior because the child hasn't learned to cope or make decisions.
The anxious controller.
That's a good way to think about it. And then the more extreme ends, like rejection or under-affection, which can lead to aggression or deep insecurity, even if the child seems superficially well-behaved.
Given all that negative potential, it makes sense why dentists often prefer parents wait outside the treatment room.
Generally, yes.
Yeah.
Unless the child is very young, say 1 to 3, or it's the very first visit, or if the child has special needs.
But why exclude them otherwise? Isn't parental support good?
It can be. But the clinical reality, according to the sources, is that a parent's presence, especially an anxious parent, can unintentionally reinforce uncooperative behavior. The child might play to their parent.
Yeah, okay. So the dental team needs to kind of take charge of the immediate environment.
Temporarily, yes, to guide the child effectively without that other dynamic interfering. But getting parental cooperation for this requires clear instructions. The sources list 10 rules for parents.
10 sounds like a lot to remember. Can we boil them down?
I think so. You can really group them into 3 core mandates for parents. First, stop the negative talk. No sharing your own fears. No using the dentist as a threat. Simple but vital.
Okay, mandate 1, no negativity.
Second, don't make the visit seem like a bad thing. This is where the never bribe rule comes in. Bribing suggests the experience itself is awful and needs compensation. That just reinforces negativity.
Right, bribing backfires. Mandate 2, frame it neutrally or positively.
And third, be consistent and build trust. This means never lying, especially to older kids. Don't promise things that dentists can't deliver. Don't scold them about dental visits. Be casual, familiarize them with the office beforehand. Show courage yourself.
Mandate 3, consistency and trust. Got it. So the last piece of the puzzle is the dentist and the environment itself.
Right. Things like, how long is the appointment? Is the office visually appealing and kid-friendly? What's the dentist's personality like? Their skill, the assistants, and a really big one, actively avoiding fear-promoting words.
Like saying sleepy juice instead of shot.
Exactly. Or washing the tooth instead of drilling. Language matters immensely. And honestly, the dentist's speed and confidence are huge. Minimizing the time for anxiety to build is key.
Okay, so we understand the child, the parents, the dentist. Now, how do professionals actually classify the behavior they see before deciding on a technique? We see the obvious stuff: timid, defiant, fearful.
Yeah, those are observable attitudes. Timid kids might hide, avoid eye contact. Defiant ones might scream, refuse, often without actual tears. Fearful kids are often pale, quiet, crying with tears, but might still obey.
But there are more formal systems.
Definitely. The Frankel rating scale is probably the most widely used. It's simple. Double negative for definitely negative behavior, like forceful crying or extreme resistance. Single negative for reluctant, uncooperative behavior. Positive plus for acceptance and caution. And double positive plus plus for kids who actually show good rapport and enjoy the visit.
Okay, that gives a clear scale.
There's also rights classification, which is helpful conceptually. It groups kids into lacking cooperative ability, maybe due to age or a disability, and potentially cooperative.
And that last group, potentially cooperative, those are the kids where these techniques are really crucial.
Exactly. They can cooperate, but need specific guidance to get there. Understanding these classifications helps the dentist choose the right tool from the toolbox.
All right, let's open that toolbox. These are the behavior modification techniques. And importantly, the source is stress. These always require informed parental consent.
Always. Consent is paramount.
Let's start with the foundation, communicative management.
This is really ongoing. It starts with voice control, not yelling, but consciously changing your volume, tone, or pace to get attention, guide behavior, and establish that you're in charge, calmly. It's good for uncooperative or distracted kids.
And it's not just words, right? Nonverbal counts too.
Hugely. Your posture, gentle physical contact, eye contact, even your facial expression. Yes, even behind a mask. It all sends messages of calm, confidence, and authority.
Then there's the classic, tell, show, do, TSD.
TSD. It's fundamental. You tell them what you'll do in simple terms. You show them, maybe demonstrating on a finger or a model, using the actual instrument if it's not scary. Then you do the procedure. It demystifies things, reduces fear through familiarity. It's a basic desensitization approach.
And what about learning by watching?
That's modeling. The child watches someone else behave well, maybe a sibling getting treatment calmly, live modeling, or watching a specially prepared video, symbolic modeling. This can happen before the visit or even in the chair.
Okay. And reinforcement seems critical for shaping behavior over time.
Absolutely essential. Positive reinforcement is your go-to. Rewarding the behavior you want to see with praise, a smile, a high five, social rewards, or maybe a sticker or a small toy, non-social rewards. This makes the child more likely to repeat that good behavior.
And the sources also mention negative reinforcement. How does that fit in? It sounds like punishment.
Yeah, it's often confused, but it's not punishment. Negative reinforcement is about removing something unpleasant or undesired when the child behaves well. So maybe you stop doing something they don't like because they started cooperating. Or conversely, if they misbehave, you might remove something they do desire, like taking away a planned short break from treatment. The goal is always to increase the desired behavior by manipulating consequences.
Okay. Subtle but different. And then there's just plain old distraction.
Yep, diverting their attention from what's happening, especially during potentially uncomfortable bits like an injection. Think noise-canceling headphones with cartoons, engaging them in chat about their pets or favorite sport, anything to shift their focus away from the dental procedure itself.
Now, things get more sophisticated. The sources talk about newer, modified communicative techniques, like ask, tell, ask.
Yes, ask, tell, ask is a really smart evolution of TSD. You start by asking the child what they know or expect. This immediately tells you their baseline, their fears, any misconceptions.
Okay, you gauge first.
Then you tell them, explaining the procedure, but tailoring it specifically to their age and understanding. A 3-year-old gets a very different explanation than a 7-year-old or a 14-year-old.
Right, gotta match the developmental stage.
Then, crucially, you ask again, okay, so what did you understand? Do you have any questions? This checks their comprehension and lets you correct any remaining misunderstandings. It's a feedback loop.
I like that. What about enhanced control? That sounds empowering for the child.
It really is. It directly addresses the fear of helplessness. The dentist gives the child a signal, usually raising their hand, and promises that if the child gives that signal, the procedure will stop immediately.
Wow, really? Stops completely.
Stops completely, at least for a moment. The key is the child learns they do have control over the situation. It builds immense trust, reduces anxiety, and paradoxically makes them less likely to actually use this signal because they feel safe.
That's fascinating. Okay, the most complex sounding one was memory restructuring. How on earth do you restructure a memory?
It's a cognitive technique mainly for kids with maybe mild anxiety or slight misbehavior based on a previous visit, not for severe cases. It has 4 steps. First, the visual primer. During a good moment in the current visit, maybe they sat still for polishing us. You snap a quick photo of them looking relaxed or smiling.
Okay, capture the positive moment.
Second, visualization. At the next appointment before starting, you show them that photo. See? Remember how brave you were when we polished your teeth last time? You did great. You anchor them to that past success.
Reinforce the positive memory.
Third, completion. You encourage the child to verbally tell their parent, I was really brave when the dentist cleaned my teeth. This reinforces it again through their own words.
Active recall.
And fourth, the success goal. You use that photo, that memory, as evidence. You were 30% brave last time. Let's see if we can get to 70% this time. I know you can do it because here's the proof. You're using their past self to motivate their future self.
That's quite sophisticated. Now, shifting gears to the techniques that involve more physical control, hand over mouth or HEOM. The sources are clear this is largely abandoned in many places.
Yes, very clear on that. It's controversial and generally not favored anymore. But it's included because historically it represented an endpoint in managing severely defiant behavior, and understanding its original intent and limitations is important contextually.
So what was the specific indication?
Strictly for a healthy child exhibiting hysterical avoidance behavior where communication has utterly failed and they're completely out of control. The technique was to place a hand firmly but gently over the mouth, stopping the screaming, while calmly and quietly explaining the behavior that was expected. The hand was removed the instant the child calmed down.
The goal being?
The stated goal was purely to gain the child's attention and establish that the dentist was in control of the situation, to reestablish communication. But again, the shift towards non-aversive methods like enhanced control, focusing on collaboration and trust, shows how thinking has evolved.
That makes sense. Okay, the final category. Patient immobilization, also called protective stabilization. This sounds serious.
It is, and it's used only when necessary for safety. The sole purpose is to protect the patient from injuring themselves or protect the staff from injury and allow necessary dental treatment to be performed safely and effectively when it otherwise couldn't be.
What are the specific situations where it's indicated?
Usually it's for children who lack the maturity or cognitive ability to cooperate, perhaps due to age or a significant mental or physical disability. Or it might be considered if all other behavior guidance techniques have failed and there's a real safety risk if treatment proceeds without it.
And when is it absolutely not okay to use it?
It's strictly contraindicated for any cooperative patient, obviously, and also for any child with a medical condition where restraint could be dangerous, like certain breathing problems or severe uncontrolled seizures, for example. Informed consent here is incredibly detailed.
What kinds of restraints are we talking about?
They can be oral things like mouth props or bite blocks to keep the mouth open safely, sometimes even a padded tongue blade wrapped in gauze. Or they can be body restraints devices like a papoose board, a PD wrap, special beanbag inserts, safety belts, or sometimes just having an extra trained assistant help gently hold the child stable.
And documentation is key.
Absolutely critical. The patient's record must detail the specific type of restraint used, exactly why it was necessary, the indication, and confirmation of informed consent from the parent or guardian.
Wow. Okay, so wrapping this all up, this deep dive really highlights that pediatric dentistry isn't just about fixing teeth. It's this incredible blend of technical dental skill and deep psychological understanding.
It truly is. You're not just treating a tooth. You're treating a developing person within a family context. You have to diagnose the dental issue, yes, but also the child's emotional state, the source of their fear, the parental dynamics.
So what's the biggest takeaway for effective guidance?
I think it starts with figuring out why the child is afraid. Is it objective based on a real past event or subjective absorbed from others? From there, it's about building trust through absolute honesty and consistency, and then choosing the right technique, whether it's a slight change in voice tone, a distraction, or something more advanced like memory restructuring, always matching it to the child's developmental level and specific needs.
Right. So a final thought for our listeners to chew on. We've talked a lot about subjective fears, often picked up from parents, and how powerful they are. We also talked about cognitive tools like memory restructuring and enhanced control that give kids agency or reframe past experiences. So the question is, could these cognitive strategies be used proactively? Not just to fix problems after they arise, but maybe introduced before the first potentially stressful procedure. Could video primers or pre-visit chats incorporating these ideas actually prevent some of that subjective fear from taking root in the first place?
That's a really interesting angle on prevention. Definitely something worth thinking about.